Now coming to reversal of anticoagulation where you use protamine. Protamine is the apparent reversal drug of choice in cardiac surgery. The protamine dose which is required to counter the heparin is again controversial. Like the dose of heparin required for cardiopulmonary bypass is empirical. Similarly, the protamine drug which is required for countering the heparin is also still controversial. It was first postulated by Bull and Associate some 50 years back, where they chose a dose of 1.3 milligram of protamine for every 100 units. This was a slightly more dose of what was given usually at that time, which is around 1.2 milligram for every 100 units of heparin. Protamine is usually administered according to the total dose of heparin which is given. Usually it is given from the range of 1 to 1.3 milligram per 100 units of heparin. How does the protamine act? When you give heparin, it mixes with antithrombin 3, then comes the complex with factor A and prevents the conversion of prothrombin to thrombin. Thereby the blood is not coagulated, so anticoagulation happens. But when you give protamine, it mixes with the heparin and remove it from the antithrombin 3. Thereby prothrombin is converted to thrombin and coagulation happens. Luxuriant protamine, that is more protamine than what is required for the heparin, reduce any theoretical or real risk of heparin rebound, but put the patient for bleeding risk because anticoagulant effect of protamine. Protamine itself can have anticoagulant effect, and you give excess protamine for the heparin. This excess protamine itself can have anticoagulant effect and increase the bleeding. So, you have to be very careful when you give high dose of protamine. Protamine can also be administered at a dose calculated from the heparin concentration, which is measured by the protamine titration assay. And coming to the guidelines of using protamine, it is reasonable to limit the ratio of protamine heparin to less than 2.6 milligram protamine to 100 units of heparin. Still, the total ratio above this limit inhibits platelet function, prolong ACT and increase the risk of bleeding. As I said earlier, higher dose of protamine can increase the bleeding. It is class 2A level of evidence C, and risk of heparin rebound is high when you give high dose of heparin or when the cardiopulmonary bypass time is prolonged. In this case, you can give a protamine infusion about 25 milligram per hour for up to 6 hours at the end of cardiopulmonary bypass. This is class 2B level of evidence C. It is beneficial to calculate the protamine reversal dose based on titration of existing heparin in the blood, and this titration is associated with reduced bleeding and blood transfusion. It is class 2A level of evidence B. Protamine can be graphically derived by plotting the ACT value throughout the case and creating an heparin dose responsive curve. The amount of protamine used in this method is based on circulating concentration of heparin at the time of reversal. So, here the protamine depends upon the concentration of heparin. Because theoretically no excess protamine exists, this patient may be prone for heparin rebound and may require additional protamine. Another important way of countering this is giving protamine in two divided doses. Initially give large dose and later a small dose. This two divided dose resulted in giving larger protamine, and also it reduced bleeding by treating the heparin rebound.